Continuing with our next talk from Michigan is Professor Paul Cederna. He's a professor at the University of Michigan, and he will be speaking about RPNIs as a continuation on the surgical topic of this afternoon. Thank you for joining us, Paul. You can have the floor.
Hey, thank you so much. So let me get my screen up here. Can everyone see my screen okay? Let's see.
Can you? Yes.
Okay. You see my screen? It says my screen sharing is paused.
We see your screen. So if you just click the slideshow, I think we'll get.
You see that okay?
Yeah, we see the screen.
My slideshow?
No, we don't see your slideshow. Could you please start the slideshow with the little screen symbol?
Again. How about now?
Now.
That's good.
Good.
Great. Okay. Thank you so much, everyone. And thanks for having me. I'm really sorry I can't be there with all of you today. I was actually planning on being there up until Wednesday last week. And then we were notified that Sweden was on the restricted travel list for the University of Michigan. So anyway, I apologize for not being there, but I'm excited to be able to share some of the work with you that we're doing. So today we're going to talk about regenerative peripheral nerve interfaces for the prevention and treatment of neuromas. And so what we know is worldwide, there are an immense number of people living with limb loss. And I don't have to tell anyone in this group how many people there are out there. But even if we look at North America alone, there's 3 million people living with limb loss. And if we look at Asia, that's 25 million people. So there are an immense number of people living with limb loss, which means there are an immense number of people living with neuroma pain and phantom pain. And what we know overall is the treatments for neuroma pain just aren't that great. Anytime there are 1 million different things to do to treat pain, that means that not any one of them is actually adequate by itself. And overall patient satisfaction is poor. And the door is wide open to all of us to invent new strategies and new approaches to treating neuroma pain. And even if we look at the simplest things like pads and numbing gels and special things inside of sockets, that doesn't work. When we think of all the different medications we use, none of those work. When we think of all the injections and ultrasound guided treatments and radiofrequency ablation, they don't work. And even surgery, we think of surgery, the success rate in general is probably around 60% or less. So there is a lot of room for improvement. And clearly, there simply is a better way to do it. And it's up to us to find what that is. So when I think about neuromas, I really think about motor and sensory axons. And what they need to do and what they want to do is they want to reinnervate end organs, whether it's muscle or it's skin. And it's really difficult to stop nerves from sprouting. It's hard to get them to stop from sprouting. It's tough to get them to stop from elongating. You can tie them, you can cap them, you can burn them, you can bury them in muscle or bone, and they will just keep growing and they will just keep regenerating. And as they do that, they will create neuromas. And in an amputated limb, neuromas can be identified with imaging almost 100% of the time. That doesn't mean they're all symptomatic, but that means that it happens almost every single time. And so if motor and sensory axons need and want to innervate end organs, and if it's hard to stop them from doing that, then I believe, just like Dr. Kuiken just said, if we give them something to do, we can potentially stop that process. And I believe that one of the solutions which is shown to be really effective is the regenerative peripheral nerve interface. And basically all that is looking at a divided nerve and putting a small free skeletal muscle graft around the end, sewing it in place, and that's it. So this concept right here is not a new concept. So back in the early 90s, John Faulkner and Bruce Carlson were doing a series of experiments trying to use standard muscle grafts to reanimate paralyzed faces. And they would take a plain old muscle graft, just like the RPNI. They would plug a motor nerve into it, like an RPNI, and then they would reinnervate that muscle and use that muscle to reinnervate the face. The problem with that process was simply that the muscles didn't generate as much force as they needed, and so it didn't work that well for facial reanimation. But what was proven with those early experiments is the standard muscle grafts survived, they became reinnervated, and they contracted. So the process here is the following. You take a free muscle graft, no blood supply and no nerve supply, and you move that to the new location. And that muscle graft is nutritionally supported just like a skin graft. Imbibition, which is diffusion, inosculation, where individual blood vessels connect up from the bed to the free skeletal muscle graft, and revascularization. The muscle fibers degenerate and regenerate from the satellite cells that are positioned on the surface of the sarcolemma. And then the muscle fibers become reinnervated as demonstrated here. This process works, and it works consistently. If we look at regenerative peripheral nerve interfaces 12 months after implantation, you can actually see a beautiful green neurofilament stain with axons coming into the muscle and ending on the presynaptic terminal boutons. You can see red labeling with alpha bungar toxin on the motor end plates, which is on the surface of the muscle sarcolemma. And when you fuse them, you see beautiful, stable reinnervation of the RPNIs. Give the nerve something to do. The next question is how will we use this clinically? Well, we would use this clinically by finding a neuroma in an arm, removing the neuroma, dissecting that large multifascicular nerve into multiple branches, and then placing a small muscle graft on the end of each of those branches so that that nerve can reinnervate that piece of muscle. So the question then is, how is this actually different than simply burying the nerve into muscle? So we know from a paper that was published by Lee Dallin and Susan McKinnon back in 1986 that they were the first to recommend, I mean, this is a long time ago, this 35 years ago, recommending resecting the neuroma and implanting the nerve into muscle. And they showed some pretty reasonable results with that. So how is what we're talking about any different than that? Well, if we take a nerve and we bury it into a normal muscle, that muscle is already innervated. So we see the nerves coming down, and there are already nerves on every single muscle fiber, which means that there are no targets for reinnervation. And if there are no targets for reinnervation, if we put the nerve into that muscle, there's nothing for it to do. On the other hand, if we bury the nerve into an RPNI, every single muscle fiber is denervated, which means that every single muscle fiber is a target for reinnervation. And if every muscle fiber is available for reinnervation, we can then give the end of that nerve something to do and prevent it from reforming a neuroma. So there's got to be a better way to do it, find it. And I think this is one of the options that can do that. So Jim Leonard, who is the head of physical medicine rehabilitation, was pushing us hard, saying, I know you want to control prosthetic devices with the RPNIs, but from our standpoint, there's so many patients with neuroma pain and phantom pain. And in hundreds of animal models, you have not seen neuromas in animals with RPNIs. Why don't you just do this to prevent neuroma pain and phantom pain in humans? So we decided to take all the patients who had undergone all the standard treatments for neuroma and phantom pain and treat them with RPNIs. And in this group, if we can make them better, then this potentially has a chance. So this is our very first patient that we did. And this patient was 50 years old, had neuroma pain and phantom pain after an above-knee amputation. The patient had severe peripheral vascular occlusive disease and diabetes. They had undergone 13 operations on their leg, and they had phantom pain and neuroma pain daily for 3 years. They had been tried on all the different drugs without success, including hydrocodone, gabapentin, Lyrica, Elavil. They had done all of the other things too that are available, e-stim, desensitization, work hardening, meditation, and even had a dorsal column stimulator implanted without effect. We went to the operating room on this patient and we identified a sciatic neuroma. And what you see here is you see this area constricted. There was actually a silk suture ligature here, and the neuroma just formed distal to the silk suture ligature. We cut out the neuroma, and then we divided that sciatic nerve into 3 fascicles. We took small pieces of free skeletal muscle graft and we sewed them on the end of each of the fascicles. So you see here we have 1, 2, 3 RPNIs. And in this patient, 18 months postoperatively, they had no neuroma pain. They were wearing their prosthesis 8 hours a day. They had mild phantom pain less than once a week and no narcotics. So with these types of patients that were the ones that failed all of the other traditional methods of neuroma treatment, the fact that we could help them out made me hopeful that this might be a good opportunity for us to improve the care of patients with limb loss and phantom pain and neuroma pain. So we looked at our first group of patients. And so keep in mind, this group of patients are the entire group of people who had already had all the other standard neuroma treatments and still had neuroma pain and phantom pain. We reviewed all their charts and we went through all of their neuroma treatments with RPNIs and we evaluated their outcomes. We only looked at follow-up at least 24 months post-op because so many times neuroma studies report results early on, and early results don't necessarily mean that those are lasting outcomes. So we only looked at outcomes 24 months post-op at least. And we gave the patients a validated survey instrument, the PROMIS instrument, to evaluate them. Our patients on average were 53 years old, and on average their pain duration was 6 years, but the range was 1 to 29 years. So some of them had had pain a long time. And it was above knee and below knee amputations and upper extremity amputations as well. In this group of patients, we had performed 46 RPNIs to treat 46 different neuromas. And you see we had upper extremity and lower extremity. We had pure motor, we had pure sensory, and we had mixed nerves in this group. The donor muscles that we used for creation of the RPNIs was also highly variable, which means that we used slow muscle like the soleus, we used fast muscle like the gastrocnemius, and we used fast oxidative glycolytic muscle like the vastus lateralis. So all of these muscles had different physiologic characteristics and they all were used for RPNIs. When we looked at the patients with their neuroma pain scores, preoperatively they started with neuroma pain scores of 9 and postoperatively it went down to 2.5. So a huge improvement in their neuroma pain scores. Their phantom pain scores went from a pre-op score of 8 to a post-op score of 4. So once again, a reduction 50% in their phantom pain scores. So pretty dramatic. And equally dramatic was the pain interference score. So this is the amount of pain that somebody has that prevents them from doing the things that they want to do. And in this, their pain interference was cut in half with RPNIs. Interestingly, when we asked them if they had the chance to do RPNI surgery again, would they? There's only one patient that said they would not. And I think in this early stage, we were learning who was a good candidate and who was not. And we're aware that with amputations, people have pain from many different sources, not just neuromas, but they have complex regional pain syndromes, they have bursa, they have heterotopic ossification, they have a million different things going on that can give them pain. And I suspect that the one patient that would not do RPNI surgery again probably had pain from some other source. But this was a learning phase for us. But overall, you can see a vast majority of people strongly agreed that the operation helped them. So because we had such good results with the people with severe pain who had already failed other treatments, we thought it probably makes more sense to actually do RPNIs at the time of amputation, because if we can prevent them from developing neuroma pain in the first place, and if we can prevent the centralization of their pain, we might be able to prevent all of this from happening. So in this study, we decided that we would randomize patients to groups that would either go prophylactic RPNIs at the time of their amputations or no RPNIs, just standard treatment at the time of amputations. And we believe that prophylactic RPNIs would reduce both the incidence of neuroma pain and phantom limb pain in the patients treated this way. So in this study, we had a minimum follow-up of 12 months. And the patients that were undergoing amputation underwent RPNIs at the time of amputation were one group, and no RPNIs at the time of amputation were the second group. So when we look at our two groups, we had 45 patients in each group. We can see the mean ages were well matched, their gender was well matched, BMI was well matched. So across the board, they were pretty well matched across all the criteria. When we looked at the surgeons that were doing the operation, we see in our prophylactic RPNI group, 80% of them were performed by plastic surgery, whereas in the control group, only 16% were plastic surgery. Whereas in the control group without RPNIs, it was mostly vascular surgery, because at the time, vascular surgery was not sure that RPNIs would be helpful to their patients. So there were differences between the types of surgeons doing the amputations and whether they were performing RPNIs or not. But you also see in the RPNI group, we have orthopedic surgeons, we have vascular surgeons, and we have general surgeons. And when we look at the total number of operations, we see in our prophylactic RPNI group, there were 47. In our control group, there were 50. When you look at the number of surgeons, we had a lot of different surgeons participating in the study. We had 14 in the prophylactic group, and we had 25 in the control group. What this tells you is that any surgeon can do RPNIs, and it doesn't require any specific specialized training of any variety. And we look at the types of amputations, they were very well matched in regards to whether they were transtibial, transfemoral, transradial, very well matched. You do see that in our prophylactic RPNI group, the average operative time was longer than the control group. The average operative time was 152 minutes for the amputation in RPNIs, and in the control group, it was 90 minutes. So that is the time that it does take to do the RPNIs. Also, please keep in mind that this is a teaching institution, so these operations are all being performed by residents. You can see here the total nerves that were used for prophylactic RPNI creation. Once again, we had lower extremity and upper extremity. And in the upper extremity, we even had them as proximally as within the brachial plexus, the median cord, lateral cord, posterior cord. We have mixed nerves, motor nerves, pure sensory nerves. And there were 159 total RPNIs done in this study. And in our control group, the complete mix of things that people do were done here. There was traction neurectomy, suture ligature, buried in muscle, simple transection, some combination. So that was a very fair representation of what a control group would look like based upon what current management of patients is. So if we look at our postoperative complications, we see in yellow is our control group, and in blue is our prophylactic RPNI group. We see lower delayed wound healing, lower surgical site infection, and lower complications overall in our prophylactic RPNI group. I think this is because of case mix more than anything, because there were more vascular surgery patients in the control group. So I think partly that's why we're seeing this difference in complication rates. If we look at their postoperative pain outcomes with a mean follow-up of 1 year, at 1 year, we had 13% of our control group develop symptomatic neuromas that required surgical intervention, and 0 symptomatic neuromas in our prophylactic RPNI group. When we looked at patients with phantom pain, we saw 90% of patients in the control group had severe phantom pain, and we had 50% of them in the prophylactic RPNI group that had a substantially lower intensity pain and less frequent, but still some phantom pain in our prophylactic RPNI groups. So what have we learned from this? If we give axons something to do, RPNIs are really promising. And a majority of the patients are reporting very significant decreased pain scores and a high level of satisfaction, and it's easy to perform. Any surgeon can do it anywhere. We've done over 200 patients to date, and over 500 RPNIs have been performed just by me alone here at the University of Michigan, both for prophylactic RPNIs and to treat existing neuroma pain and phantom pain. So it's a very exciting process. So now in the last few minutes, I do want to just share a little bit about prosthetic control. And so RPNIs were originally created for the purposes of prosthetic control. And in these patients we are doing RPNIs on, and in this particular case, this is a patient with a transradial amputation who had one median nerve RPNI done, one ulnar nerve RPNI, and one radial nerve RPNI. We had these patients, we could then implant electrodes into their RPNIs and have them control a prosthetic device. And so this is the very first patient we implanted who has 8 bipolar electrodes implanted into his RPNIs and residual innervated muscles. And if we look at the signal-to-noise ratio across all 8 bipolar electrodes, we see a signal-to-noise ratio of 65. The reason this is exciting is this is demonstrating to us that the RPNIs are amplifying the very tiny efferent motor action potentials, which allows us to very easily determine what motor intent is of the patient and provide prosthetic control based upon that. So here you see, I'm going to stop this for a second. Here the white hand is telling him what to do. This hand in the back is him doing it using his RPNIs. When the hand is green, he got it right. And when it's red, he got it wrong. And this is him. He would do 250 consecutive trials. Here we have him starting at trial 89. So you see here, he's got thumb extension, index finger flexion, thumb flexion, index finger extension, wrist flexion, finger abduction. So he has intrinsic hand control, ring finger flexion, and finger adduction. So at this point already, we are demonstrating better motor control of a computer avatar hand than even the prosthetics are capable of providing at this stage. Here, this is week 1, and he's just moving his thumb through space, putting it into this dot. He then returns week 2 without any recalibration or anything. He just plugs in and he starts using it. This patient went 360 days without recalibration, was able to totally control all his fingers. Patient 2 is now over 2.5 years without a single calibration, still being able to use their fingers normally. This is him. This requires 4 independent signals to give this degree of thumb control. He has FPL and EPL, and he has median nerve RPNIs. Here you see a standard box and blocks where he's doing a thumb index finger pinch. But interestingly, as he scoops these up, you see him move his thumb out of the way. He's going to scoop up a couple, move those over. So you can see he's kind of using this relatively normally like a hand. It's pretty easy for him. Now you're going to see a Shap test. He's going to turn this key, but he's not going to turn it by turning his wrist. He's going to turn it by moving his thumb in relation to his index finger, like you or I would. So it's pretty amazing his ability to turn that key without just rotating his wrist. So if you watch again, watch his thumb and index finger. He just turns them in relation to each other. That's the intrinsic control of the thumb that is so important. That's given him that degree of control. This is the deca hand. So the middle, ring, and small fingers all move as a single unit. So he doesn't have independent finger control with this hand because it doesn't have it. But you can watch how quickly he can move between these functions without having a mode switch. All he does is he just thinks about it because he's got 8 independent control signals. And you can just see him just move these things just at will, just like it's his normal hand. So it's pretty remarkable. And here you'll see just some easy grasps. He just goes to a typical fist grasp, a pinch, back to a grasp, back to a pinch. And you see he's in different positions too. So all of this thing related to being only able to function in a research lab isn't necessarily the case. So our second patient with electrode implantation, she was 35 years old and she had bad necrotizing fasciitis, and she had all sorts of attempts at limb salvage and ultimately was left with her right hand, which was painful, neuroma pain and phantom pain, and didn't move at all. She elected to have an amputation of her right hand, and she proceeded with a transradial amputation and had regenerative peripheral nerve interfaces implanted so that she could have better prosthetic control. And here you can see this is the same thing. This is her hand that's telling her what to do. This is what she's doing in the back. This is her controlling her computer avatar hand here. And this is her with her normal hand trying to do the same thing. And you can watch finger abduction, thumb flexion, finger extension, thumb extension, small finger flexion, finger abduction, thumb flexion, index finger flexion, thumb extension, small finger flexion, thumb opposition. And she is just flipping between these functions without even thinking about it. It is really remarkable how easy this is to do without any training because her body is simply doing what it did originally. This is her pronation, point, pinch, and this is just her moving through these functions. And once again, it doesn't require any mode shifting. It doesn't require a switch in her shoe, a tongue switch, nothing. It doesn't require her firing muscles that aren't supposed to fire. She's just doing things intuitively like she did when she had a hand. And this is her with her prosthetic hand. This is an eye limb, and you see she's got small finger flexion, middle finger flexion, and she's using each of her independent channels to do this. And you can see thumb, all 5 fingers she has control over independently. And she isn't doing any mode switching here to make this work. This is just simply her controlling it with her 8 bipolar electrodes. So where are we now with motor control? We have stable RPNIs in humans now for 4 years without any decline in signal-to-noise ratio or quality of the signals. Those signals are amplified dramatically, and across the board, they're somewhere between 60 and 100-fold the size of an efferent motor action potential, which allows us to record them easily. The signals are really high quality, so it's easy for control. We can interface with as many fascicles as we want. And it can be performed on people years and years after amputation. So I'm really excited about the progress we've made so far. We just recently implanted our 3rd subject about 2 months ago, and he is doing great. I want to thank all of our funding sources, DARPA, the Department of Defense, Army Research Office, Plastic Surgery Foundation, the Hand Society, and the NIH. We have an amazing group of people. Lots and lots of people have contributed to this in all levels. And I'm happy to have a chance to share all this with you, and I'm happy to answer any questions that anyone has. So thank you so much.
Thank you, Paul. We have a couple of questions for you. The first one is, which questions have been used to test the neuroma pain versus phantom limb pain? How can you highlight the difference in the questionnaire?
The questions?
Yeah, so basically how you differentiate between the two.
Yeah, so neuroma pain, when we describe it for people, neuroma pain, we talk about very specifically as pinpoint tenderness in one spot. They can put one finger and touch the spot, and that's the pain. The phantom pain is the pain that they're experiencing in the limb that has nothing to do with their residual limb, but the absent limb. For some people, it's very difficult for them to understand the difference between phantom sensation and phantom pain. And for some people, like when they say the end of my baloney amputation residual limb is tender, a lot of times that just might be their bursa on the end, or it might be HO, or it might be something like that. And so neuroma pain is a single finger pointing to a spot, and you hit that spot and it gives them that exact pain. So,
right. Thank you. And the next question highlights really exciting results. Do you think the RPNIs will be effective for patients with pre-amputation pain?
With what kind of amputation pain?
Pre-amputation, prior to the amputation.
Oh, well, so that's a great question. So one of my partners here is actually doing RPNIs on people that have all sorts of pain for other reasons. So when women get mastectomies, a lot of them get horrible breast pain because they have neuromas of their intercostals. So he's been doing them for that. People with knee replacements have horrible knee pain, and he's been doing them for neuromas, the sensory innervation of the knee. So we've done it in a lot of patients. He's done hundreds of patients now that don't have amputations but have neuromas. For patients that are going to get amputations, I think the answer is really getting their amputation and doing their RPNIs at the time of amputation, so they never set up that centralization of their pain. Because once that centralization sets up, I think that's where that long-term phantom pain persists, even after someone has TMR or after they have RPNIs. That's, I think, where that comes from, is that whole centralization mechanism. And we're going to need to figure out a way to communicate with the brain so we can reduce that over time.
And I suppose prosthetics is a good way to do that, huh?
Prosthetics also, I know. And I will tell you that the first 2 patients had horrible neuroma pain and phantom pain. And when we got them hooked up using a prosthetic, they had nothing and still no phantom pain at all. And so allowing them to embody a prosthesis might be the best way we can help them. Mm-hmm.
Thank you, Paul. I hope you can stay for the panel discussion.
Absolutely.
Sorry.